Good morning, everyone. Our speaker today is Dr. Gary Procop, and Dr. Procop is the CEO of the American Board of Pathology. Before he joined the board as its chief executive officer, he was the medical director of clinical microbiology and the chair of clinical pathology at the Cleveland Clinic.
Recording in progress.
At that time, he also served as vice chair for education. Dr. Procop was a trustee of the American Board of Pathology from 2007 to 2018, and he served as the president of the board in 2016. He became a life trustee of the board in 2019, and then he followed Dr. Rebecca Johnson as CEO in January of 2022. Dr. Procop's interest in medical education is apparent from some of the really exciting new initiatives that he has already started at the American Board of Pathology. And I am really excited and anticipating very much having him share with those new initiatives with us this morning as he talks about the American Board of Pathology, past, present, and a bright and bold future. So thanks, Gary, so much for doing this.
Thank you, Dr. Powell, one of our life trustees, and we appreciate you paving the way for many of these initiatives. So with regards to objectives, we want to tell you about where boards came from, some of the things that we're doing, again, past, present, and future. Some of the describe the components of continuing certification program. Important to recognize some of the differences between formative and summative assessments, since you'll hear some of those terms. And I want to share with you three of our exciting outward-facing initiatives. My conflict, of course, is that I'm employed by the board. So we will try to navigate through the alphabet soup, and we'll begin here, wherein we see that the American Board of Pathology in the center is a member of the American Board of Medical Specialties. And so we're one of the 24 member boards of a federation. We, of course, have a variety of other interactions, right? And so we have a wide variety of cooperating societies. You'll see a list of those in the talk today. And we have a place at the table with ACGME in reviewing pathology programs on the Pathology Review Committee. We put together primary and subspecialty certifications, and as well as now continuing certification. So this is where we sit in this alphabet soup. And so American Board of Medical Specialties, very important group, an overseeing group, if you will, of medical boards. And so they are celebrating their 90 years. How did they come into being? Well, but before 1900, if you wanted to claim you were a pathologist, you could claim you're a pathologist. If the next day you wanted to claim you were a orthopedic surgeon, you could claim that, because there really was no way for individuals to show their training, their expertise, etc. Real problem for the public and real problem for other medical professionals who wanted to refer people refer patients to specialists. On the bottom of this slide, there's a nice reference to the history of our board that was published back in '86 in the Archives of Path and Lab Medicine. So what had happened was boards began to form on their own. So the ophthalmologist started it, followed by the otolaryngologist, OBGYN, and then dermatology. And you can see what was happening in the world pre-antibiotic era when they were also called the Board of Dermatology and Syphilology. So a lot of secondary syphilis at that time. These boards had formed independently. And then essentially there was a decision, a conference held in 1933 that said, you know, we really need an overseeing board make a federation of all these different boards. And so that is really how American Board of Medical Specialties was eventually formed. And it was originally called the Advisory Board for Medical Specialists. And so how about the history of AB Path? Where did we come into being? Well, it was not long after that. It was 1935. And AMA, and yes, ASCP was around then. AMA and ASCP had a joint committee, and they agreed that it was important to have a national certifying board in pathology. And so bylaws were drawn up. And by the next year, they nominated members, and the AB Path was incorporated in Michigan and really became one of the boards, and still is, the pathology representation on the American Board of Medical Specialties. And so if you were to pull, and it's in that article I referenced, if you were to pull the original bylaws, so what did our forefathers, and they were all fathers at that time, what did our forefathers think, and how does it align with what we're doing? Well, if you read these, you can really see they were interested in things like lifelong learning, like we're interested in. They were interested in improvements in medical practice. You'll hear these terms when we talk about continuing certification. And they were interested in the assessment of knowledge, judgment, and skills. And so I believe we really are. We have stayed true to our original Constitution, if you will. And so this is some images of some of our original, the original trustees, if you will. And here is the original logo. And I never knew what that was. It always looked like a dystrophic brain to me in the background behind that microscope. And it turns out it's mycelium coils of intestine. And it's my understanding that this is an archaeological find, and they thought it was the first etching into stone of human intestines, and the first representation of gross pathology. And so we have Hooke's microscope and the Asclepian serpent around it, representing medicine resting on a foundation of pathology. And this is what what the examinations looked like back then, right? And so here there were gross examination stations, and it's my understanding that at that time there were, say a slice of lung that was in in some kind of a plastic sealed baggie. And of course, pathologists being who they are, they wanted to pick it up and palpate it. And so by the time the last examinee got to that baggie, it was a bag of mush. So not really the best the best way to do it, but that's the best they could do at that time. Written examinations. These were all usually performed in hotels. My first, my APCP was in a hotel, and my subspecialty was here in Tampa. And here are some images of the microscopic examinations, during that time, way back in 1962. So that's where we were, and now I'll take you back to the future, and we'll talk about the ever-evolving AB path. And I really like that we have a compass here, because if you are navigating, you're going to take readings, and every once in a while you're going to readjust course based on where you are. So it really is ever changing. And so we began with a primary certification. It was a one and done. You were certified for life, and as not just us, but really the entire board's community and education in general learned that education, it's a lot like entropy, right? It will decay unless energy is put into it. And so energy really is in the form of lifelong learning. If you want, if you finished training and you're at the top of your field, if you're going to stay at the top of your field, it's going to take some work. And many people do that naturally. Some people don't do that. And so from a protect the public standpoint, continuing certification is very important. And all of the boards now, if you want to be within that federation, you have to undertake continuing certification, and we do. And I'll tell you some of the ways that we do that. We've tried to really increase, and moving forward, we're looking at opportunities to increase collaboration with our academic partners, our cooperating societies, be very transparent, you'll see, about what we expect of people, and have really meaningful interactions during training. Right now, we do not do anything with our trainees during training. Many other boards do. And so what are some opportunities that we could take there? And we'll show you some of the things we're thinking about. And then actually looking at competency, not just knowledge. Knowledge is for sure the base of the pyramid and extremely important. and we do a great job assessing it with our current examination. But to get at the top of Miller's pyramid, and you'll see an example of that in a little bit, you're really getting at how can you assess competency. So with some of these changes came a change in the logo. And so a few years back, led by Dr. Weiss as our trustee of chairing that committee, the logo has changed to the traditional microscope representing cellular pathology and laboratory medicine, sitting on the double helix of evolving discipline in the molecular era. So if you haven't had a chance, go to the website. It's a new website, a lot of smiling faces back at you, even though we love looking at things on the other end of the microscope. We're people friendly too. And I hope you'll find a diverse group of individuals looking back at you and an easier to use website. On there, you'll find our mission statement. You can see that we really do serve two masters. We serve the public and we serve to advance the profession. How do we do that? We do that by setting certification standards and promoting lifelong competency of pathologists. And we believe our vision statement below that we will improve the health of the public when we promote the excellence in the practice of pathology. So what are some of our principal activities? We establish certification and continuing certification standards, assess qualifications of individuals, conduct voluntary and subspecialty certifications, as well as require the diplomates to, if they want to continue to be certified, participating in continuing certification. We also participate in the review of pathology training programs, and I want to underscore, support the directors and the trainees of these programs. That is what I think many of our newer initiatives are working to do, is really support our people in training. We want to maintain communication with the broader pathology community, really trying to make these things a community effort, encourage the study of pathology, and we maintain a registry of our diplomates. So I'll introduce you to the individuals who are our officers. And so we have Dr. Barbara Sampson, who is our president this year, Vice President Moe Gafrani, Secretary Kathleen Beavis, Treasurer Mark Fund, and our past president, Dr. Ritu Nair. The remainder of our trustees are under the heading of current. And then a number of years ago, we brought on our first public member. And all of the boards have been encouraged to bring on public members. And at first we thought, how is a public member going to help our board? What do they know about pathology, et cetera? So we took the tact of bringing on public members that really had a skill set that could help the board. And so our very first public member, Dr. Constance Filling, an expert in education, and she has been really key in many of the initiatives you'll hear about today. Unfortunately, her term is up, and we'll miss her, even though she told us she's happy to keep working with us, and we'll probably take her up on that. We were fortunate to recruit Dr. Russell. Dr. Russell works with a team that puts together the MCATs and is a psychometrician. So our psychometrician was very happy to talk deep math with somebody else, because there's no one else in the office he can talk that deep of math with. We just glaze over when he starts. So this will be another great addition to the to our board, and we're excited about that. Here's your team, myself with all of your trustees. I hope you can appreciate from the very first picture of our founding fathers that we have a very diverse group of individuals. They are diverse not only in gender and ethnicity, but also in practice, geography, etc. And we just have a wonderful team that is looking after. They are the trustees of your board. This is the team that works behind the scenes to make it all happen. And the young lady who is highlighted, she was just hired in as our test development advisory committee coordinator. The young lady in blue, Clarita Socia, retired after 37 years at the board. So it must be a pretty good place to work if they'll stick around that long. So this is the team that gets it done for you day in and day out. Our professional interactions every year in May, we meet with all of the cooperating societies and, host a dinner and a interactive session the next day where we give them updates from the board, but we also ask things of them. I'm going to ask a lot of them this year. And so we'll see how that goes over. But it's been a great back and forth. We want to hear what our community has to say. You will see in slides to come. We are not a white tower. We're not an ivory tower. We are part of the process. So communication to diplomats and educators, we think we do a pretty good job of this. We're trying to do even better. We put together annual reports, newsletters. We have a communications director, so messages will go out on all of the social media. And even though we've had one in the past, it really has taken on a new life this year. We have a speakers bureau, and so like this slide deck that I'm using, this will be available to all of our trustees, and we're actually scheduling our trustees to try to go to every residency program in the country at least once every 4 years. So residents have the opportunity to hear about the board and from a board trustee member or myself during their 4 years in training. So just wanted to call out, of course, every organization has a variety of committees that get all the work done. I wanted to call out a few committees here. Our test development and advisory committee, because individuals are often interested in how is a test made. And so I wanted to share with you that. I also wanted to share with you, and I'll do that right now, that we have a continuing certification advisory committee. These are younger pathologists who are in the trenches participating in continuing certification, and they are not afraid to tell us what they think of it. And so their feedback has been really instrumental in making that program better. And so this is a great example of, not being an ivory tower and do whatever we want. We want to hear, we want to make things better. Similarly, we have a resident fellow advisory committee, and we talk to them about issues that are going on at the board, ask them their opinions on some of the initiatives that we'll be talking about today. So with regards to the test development and advisory committee, we call those TDACs for short. These are usually chaired by a AB Path trustee. They're all chaired by an AB Path trustee, and they consist of content experts. So we look around the country for experts in the areas of subspecialty that we need. We give them an invitation. All of our workers here are voluntary. And so we're very proud of that. Everything we do is voluntary, and the folks really put their heart into it. They are going to write items for the primary exam, subspecialty exam. Sometimes they'll look at information. We have separate TDACs for continuing certification. They will also review items. So if we may write an item that we think is, a thing of beauty, we put it on an examination that doesn't function well. So we'll send that back to the test committee, and they will review it and see perhaps why it's not performing well. They also participate in standard setting, which is how we determine the cut score of an examination. So just some general guidelines that we use. We avoid imprecise terms, may, often, frequently. We're very concerned about content validity. Is the item measuring what you want it to measure, and is it constructed appropriately, right? We don't allow negative stems. We want uniformity in distractors. So there's a lot of rules around. These aren't our rules. There are organizations that this is what they do for a living, and we'll adopt those standards. National Board of Medical Examiners, for example, has great information on optimal test item writing, et cetera. And then really an important philosophy. We really want our board to be relevant, need to know information. I don't want questions on somebody's favorite gene of the mitochondria that we really don't care about. I'm happy somebody's doing research on that. It may be super important one day, but if it's not need to know for a practicing pathologist, we really don't want it on this examination. So we really want to keep this to be a relevant exam. And that's what I tell residents and fellows. Dr. Procop, what should I study? I said, you study what you need to be an excellent pathologist, and you will do fine. And it's true. So how do questions come in if we start at 12 o'clock? The test committee member, who remember is expert is going to come in the door with a question written. And we tell everyone during these, and Dr. Powell probably remembers hearing this and telling people this, leave your ego at the door. And that is a mantra we have maintained over the years. And because these are all experts and not everybody appreciates your poetry. And so it's going to be reviewed at the test committee meeting, and it'll be massaged and hopefully be made better. But it'll either be accepted or not accepted. And if it's not accepted, it could be reworked and brought back, or it might just be eliminated. The ones that are accepted, sometimes those need a little bit of rework. These will all go to medical editors, so we have a standardized format. These will enter the ABPath database, and when the trustee creates an exam, they will decide whether to use it or not use it. If it's not used after a while, they'll eventually go back to the TDAC. Why are we not using this? Is it out of date, etc.? Have the guidelines changed and the like. If it's used, we'll see how it actually does. So we're going to get exam statistics on every single item in our exam. And so if they're acceptable statistics, it'll remain in the item bank and can be reused in additional years. If it's unacceptable, it'll be sent back to the test committee. So you can see there's a lot of effort that goes into questions being relevant and meaningful, as well as accurately constructed. And so this really makes our test, I believe, of the highest quality and defensible. COVID made us move. My surgical pathology friends and anatomic pathology friends, I think their mantra was, you can take my slides and microscope when you take it from my cold dead hand. But COVID changed all that. We had to move to Pearson VUE. And when we looked at the performance of candidates on the exact same question, glass versus virtual, there's no statistically significant difference. So they're doing just fine with the virtual microscopy. We have ways that you can practice that on the website if you haven't had those skills, but everyone seems to be doing fine. So the big plus, and we queried our candidates, we're asking the people what they want, and they wanted to stay at Pearson VUE rather than come back to Tampa, because there's often a Pearson VUE center near you. And so if you have kids, etc., it really makes for a much better experience. You can be away for the day rather than being away for a few days. Imagine if you were coming from Hawaii to Tampa to take an exam, you get the issue and the expense. So Pearson VUE is where we give the exams now. And so our exams, again, they are weighted towards practical questions. We really decrease just simple recall questions. We really want some reasoning. We have listed blueprints. These will tell you what percentage of questions will be in each area of the exam. And you'll see we're going deep on a new initiative to give much more information to our trainees than just this. This is really a 30,000-foot view where you really need a 10,000-foot view on what's important for certification, and we'll talk about that in a bit. So for our primary certification, I believe we have high-quality test items. We have the blueprint I just showed you. The test is assembled by the trustees, reviewed by the staff and myself. We have secure exam administration, standard psychometric assessment. We use a modified Angoff standard setting method primarily for our cut score determination. And all of this, of course, is reviewed by the Board of Trustees, the Committee on Exams, and then the full board. And then we'll determine from these, who gets to have the certificate from the American Board of Pathology. Here are the pass rates from the most recent primary examinations. And at the bottom of this, you can see the 5-year running totals for these. AP has been in the mid-80s, and for the last few years, CP in the mid-90s. Interesting, this was flipped about 10 years ago. So those are our scores. These are all in our newsletter, so I won't spend much time on these. Just go to our website and pull that down if you're interested. Our subspecialty scores. This is important to show because last year there was a significant dip in subspecialty pass rates on all subspecialties except derm path and forensic path. And we did a deep dive on that. We believe that was a COVID effect. When we look at items that were present on both the current exam and the previous exam, gave us a insight into the performance of those individuals on the exact same questions, and there was a decrease in knowledge in that group. We have written a letter to the editor on AJCP on this and explained these findings in more detail. But if you think about it, these folks, the folks last year who were taking their subspecialty exam, they were in their 4th year of training during the incoming hit of COVID. And then during their fellowship, I pulled CDC data. That was when the greatest amount of hospitalizations actually occurred, or in the 2nd year, their fellowship year. So they had a pretty tough time during training. But anyway, the good news is the pass rates look like they're back to previous standards. And you can see on the right, and again in our reports, how many certificates we give out in all these different areas. Cytopath and heme usually are always the lead. So we believe that ABMS and ABPath examinations and certifications demonstrate to the public that a candidate has the requisite knowledge, judgment, and skills in pathology or subspecialty to practice safely, competently, and independently. And we're doing a lot more work to prove that. Exam date windows, important because there has been a change this last year. There is no late application anymore. For a variety of reasons, that was often being abused. The other reason is now that we're with Pearson VUE, we have a real production schedule to meet in order to have that test come out on time. And so when the door to the airplane closes, the door to the airplane closes. And so if candidates are not in by then, their material, they have to wait for the next sitting. And so that's just really a production schedule issue. We mail all program directors, all program coordinators, and now we've started mailing all 4th year residents. So we're doing the best we can to remind people. So for your program directors and the like, just remember that with regards to exam windows. So moving on to continuing certification, even Michelangelo told us that at 87 years old, he is still learning. And we have here from Isaac Asimov, education isn't something that you can finish. So we're firm believers in continuing medical education and continuing certification. Everyone who has a certificate is automatically enrolled in continuing certification, and we'll talk to you about what they need to do to stay certified. So it is voluntary, but if you want to maintain your certificate, it's something you have to do. We believe in it. All the trustees and the CEO are participating. We'll break it into 4 parts. I'll hit these quickly, but we believe we are aligned with ACGME core competencies and a commitment to lifelong learning and competency. So these are the 4 parts, and as I mentioned, we'll hit these quickly, so hopefully we have some time for questions. Professionalism, professional standing, really a surrogate is medical licensure and medical staff privileges. Where do you work? And there's a 2-year reporting cycle for this information. Lifelong learning, send us your CMEs. And we do have, if your group participates with ACCME, your CMEs will come over automatically to the board, so you don't have to upload those. And you'll see there is a learning component to participating in ABPath CertLink. I want to talk for a minute about formative versus summative assessments. What are the differences here for folks that, this isn't part of your normal language? Is formative assessments are really low stakes, and they usually carry no grade. Whereas summative assessments, think about those as the traditional board exam. At the end of training, at the end of a class, you're going to take a pass-fail exam. And so if we looked at these side by side, formative assessments really are going to help students find out what they don't know so they can learn it. They're going to often do it throughout the course. It'll identify gaps and point them towards learning material if it doesn't provide it. And it'll use approaches that support specific student needs. In contrast to, as we mentioned, I think we all have a good handle around what a summative assessment is, usually at the end of training, and does this person meet this mark or don't they? That's going to be important for some of the things that we'll be talking about, particularly in part 3, assessment of knowledge, judgment, and skills, because it really has a formative approach. There's a summative decision made. Did you complete all of your parts at the end of 4 years? But the assessment is really designed to be predominantly formative. So if you think about what we used to do, so it's kind of like, you've always heard, if you only have a hammer, everything looks like a nail. Well, that's the same for boards, right? All we did was give a great big giant high stakes exam. So when it came to recertifying people, what did boards do? They gave a great big giant high stakes exam. And if you talk to educators, they'll say this is probably the worst thing you could do to assess knowledge over time, is to make people binge and purge once every 10 years, and with material that is not relevant to their practice. I do infectious disease pathology and microbiology. Do you really think I should be testing in cytopathology and blood bank anymore? Because those days we evolve with our practice. So in its place, our trustees have worked to tailor assessments to individual practice. So very difficult to do, but done. Working to decrease burden, decrease stress. It's not a high stakes exam. It's not, pass, fail, and you're going to lose your job, etc. We want to increase value, help you in your practice, increase relevance, make it something that is important to you, and help you to do better in your job. So we're balancing this. You get a little bit of core categories, something everyone should know in AP or CP, safety, etc., ethics. But for the exam itself, guess what you do? You design it yourself. So my exam, besides my core categories, is all microbiology and infectious disease pathology. And guess what? The ball should leave the park every time. If you claim to be a breast pathologist and you build a breast pathology exam and you can't hit 60%, you're probably a threat to the public. So it also simulates real life. It's open book. You've got 5 minutes. Believe me, in some of the core categories which need to be tuned up a little bit, I've been asked questions I haven't thought about in years. 5 minutes is a long time to Google the answer or use ChatGPT, right? Just remember, you're responsible for assessing what comes out of the AI engines. So it has, and again, this is part of being with a federation. We could never have afforded to build this. This was really built for a number of boards through ABMS, and that's who administers it. But you get a nice comparison. How are you doing to other people that are taking the same questions as you? Your individual performance, this person's at 80%, they're doing great. How many days do you have left to finish it? So a nice dashboard to look at. You're going to get 10 to 15 questions a quarter. You can answer them anytime. You're asked about relevance and confidence. If it's not relevant, we'll relook at the question. Maybe it's been miscategorized. You're going to get feedback on that item. And so you're going to be told whether your answer is correct or not. You're going to get a critique with references, and then immediately get an opportunity to answer a second time. That doesn't count towards your score, but it does tell us whether you actually read the critique and learned anything immediately. But then what's beautiful is you're going to get that same question 6 months or so later, and we're going to see how you do. And we actually just got done looking at that data, and there is definitely evidence of learning. So you'll reinforce it if you get a repeat question. If you missed it, you got an opportunity for redemption. This is where certification meets religion. And what that means is if you get it right the second time, we mark your miss off your total score because you learned something, and that's really what it's all about, right? So really a different formative approach to assessment for individuals who are in practice. You folks with non-time limited certificates, come on down. You can participate in a voluntary manner. There's no risk to your certification. You can get some CME from this. And if you don't want to do that, we always need volunteer item writers. So contact us if you'd like to do that too. Every year, our number of diplomates, of course, has gone up, and we're over 11,000 now in CertLink. So CertLink is a very important program, and we think there's great opportunities to help those who are in practice in a very friendly way. And that was very different from the high-stakes board exam. I'll just briefly say, we had to get that program up and running, and we did. We have now a major quality assurance, quality improvement initiative to make sure every question in there is vetted, because as you know, guidelines change over time, et cetera, to make sure our questions are in that bank remain relevant. Improving health and healthcare, that's part 4. And so what we did, we said, look, pathologists were doing quality before quality was cool. So let's just give people credit for what they do already. So just keep track of if you participated in lab accreditations, a quality committee, slide review, slide proficiency testing, implementing a test utilization initiative, OOP, or if you're a voluntary item writer. All of these, and there's a long list on the board website that gets you credit for things you already do in quality to improve health and healthcare. So we've tried to make that easy by giving you credit for what you already do rather than make you jump through another hoop. If you have to do something, we have to do continuous certification in order to stay in that ABMS tent. We also believe in it. So this is something we have to do. Medicine you have to take. Medicine can either taste like castor oil or it can taste like bubble gum. And so we really want continuous certification to taste like bubble gum. We want to be viewed as a valued lifelong partner in learning, keeping the value high and the cost and burden low. These are our goals, and we're working hard to do it. I think you'll appreciate that. As mentioned, we are not an ivory tower. We are part of the cycle of, and this is from a book on the steps of curriculum development. We are part of the education process. And you can see it's not just a cycle, but it's a lot of different interactions. So we are part of that. And it's important if you separate assessment from education, both suffer. So working hard to be a resource to program directors and trainees. Resident orientation video. We'll talk about the histology primer in a minute. Booklet information on the website tells you everything you need to know. Blueprints of the exam you've seen. By the middle of this year, we will have a web page that talks about guidelines and key manuscripts that will be put together by we're asking our cooperating societies also, as well as our trustees and test committee members. And the reason this started is I have to proofread all of the exams, and I would see that somebody would say, according to this guideline, and I said, did anyone ever tell our residents that that guideline's important? And of course, they didn't in a unified sense like we could on our website. So we're trying to do that to increase transparency and again, provide some guidance. Working hard to get manuscripts in the literature. And so I think doing a good job on that. So just had a couple other acceptances. So look for our work there and you'll see what's going on at the board. Some recent outward-facing strategic initiatives that we're very excited about. Histology primer, content specifications, competency-based assessment. And so the first one, we queried the program directors through the PROD's website and did a survey. And the vast majority said that individuals coming into pathology had less than adequate histology training or poor. Very few were adequate. None were better than adequate or excellent. And then a great paper out of University of Michigan that demonstrates in these new thread curricula where it is not a pathologist or a true anatomist teaching the histology portions that the scores are below are below standard. They're substandard. And so the argument is if you're being a pediatric endocrinologist or a cardiologist, it might not matter. If you're being dumped into the deep end of surgical pathology or autopsy, probably matters. So the board has taken a step forward. This is to help with the UME to GME transition predominantly, but we also want to let medical students know we exist. And again, we think this is an initiative. So we built a primer. You log in, you have to log in. It's all free for everyone. You have a main menu, and you can go down a variety of different pathways. Every page has a scrollable text that you can read. If you're lazy, you can click on the mini lecture and you'll hear me tell you everything you want to know about hyaline cartilage. You can click on virtual microscopy and pull up the virtual images and actually see those. And at the end, there's an optional quiz. And so it's a little 10-question quiz. You can take it as many times as you want. This is all formative, all free, and you can email your results to your program director if you'd like. So it could be incorporated into some kind of boot camp and the like. So I'm very excited about this. Launched last week, and we're getting a lot of great comments on it already. And it'll be an iterative process. When we find something, better image here or there, we will replace it. And of course, when the real histologists write me and tell me the difference between this or that, we'll tune up any areas that need tuned. So next major outward-facing initiative is building content specifications, a content outline. So the argument here is residents and fellows should not have to guess what is important for certification. Notice I'm saying important for certification because we can't cover everything. There are other things important in training, in life, in practice. But for certification, that's our lane. We should be able to tell you what's important for certification. And if you look, this has been done by and great resources if you want to check out pediatrics, radiology, dermatology, and others. These are the ones I've pulled for examples for our board. Pretty detailed. So this is more 10,000 feet versus a 30,000 foot blueprint of going through and saying what we think is important for certification. So this is a 2-year initiative. We're starting the 2nd year. I'm hoping to get it done within the 2 years. And last year, we suspended item writing for an entire year. We think this is so important. And our test committees took the first swath at walking through our category codes and looking at what we think is important for residency training versus fellowship training. Within residency training, what do we think is basic or core foundational versus advanced? We're working right now to clean those up in the office. When we have a first draft ready, that's going to be open to everyone. So again, this is a community effort. Cooperating societies, ACGME, program directors, everyone. Dr. Powell will see this as a life trustee member. And we want everyone's feedback. What do we get right? What do we get wrong? What did we miss, etc.? Working towards a document that will then live on the website and be updated every year by the test committees, and feedback can come from any groups at any time. And so we hope this is really where the assessment tail will wag the curricular dog. Dr. Warner from American Board of Anesthesiology, one of our guest speakers at a retreat, said, and it's true, test it and they will teach it. And so sometimes things are not taught in programs. If we say in paper on the website, this is important for certification, residents will go to their instructors, hopefully, and say, tell me more about this. So moving to the third outward-facing initiative, competency-based assessment. This idea in education, we'll call this educational scaffolding. You're at a different level. How do you get to the next level of increasing competency? Well, there are some different things that you have to do. I know Dr. Powell has done a lot of work in EPAs. That's one way to assess these. And there's a great EPA working group that's working on that right now in pathology. And we're an ex officio on that committee and supportive of their work. But the fact is you have to have some kind of assessment in there, right? EPAs assess in the practice, which is extremely important because it's actually happening right there. And I'll tell you what the board's doing since we're not in all of your practices all the time. So here is my cartoon, the newly minted pathologist. The surgeon asks, what's the diagnosis? And the newly minted pathologist says, can you ask me in the form of a multiple choice question? And so that's just not how Earth works. We know that multiple choice questions are great for assessing know, and some of them knows how, but they don't assess shows how and does, which is really the top of Miller's pyramid. So how do you get at assessing does? One of the ways is with EPAs. Another way is to look at simulation, and that's what we're going to look at. To let you know how important the board thinks this is, this was our retreat topic this summer. Had two guest speakers who do this differently, and we learned a lot from both orthopedics and pediatrics. And so we really do believe that competency-based assessment aligns with and supports our mission, and it promotes competency-based medical education, right? Because we've had the debate, is competency-based medical education in our lane? Well, not 100% on that, but competency-based assessment sure could be. So what we're doing is we're actually reviewing the length, format, content of our exams. Again, this is a long. These folks, it took them decades, a decade or more to do this. So this is not an overnight thing. We're going to pilot some competency-based assessment methods that will provide formative and summative feedback to trainees and program directors. So this is a different way of looking at in-training assessment, letting people know what they don't know ahead of time before they come take a high-stakes exam. And then determine the relationship of competency-based assessment with our certifications. So you can see the tack the board is taking with regards to competency-based assessment. So one of the thoughts is this, and again, it was forced by COVID, is could we build a sign-out simulation? Decided to do it in breast pathology. And so the idea, and if anybody wants to contribute breast pathology slides, we'd like them. No PHI, just a definitive diagnosis. And let's say that we have 100 of those representing all the different diseases that occur in breast pathology. We digitize all of those, and those live in a virtual slide collection. Now, this individual could study from those. That's an opportunity. But eventually they could sit down and actually have a virtual hot seat, if you will, right? So this is a safe space. That's what simulation's about. It's practicing in a safe space, doing something that you're actually going to be able to do. This young lady's decided she's ready to sit down and sign out breast pathology. She gets a random 15 from the hundreds that are in the virtual slide collection. So it's just like real sign out. And unfortunately, she got a C-. But the plus is, it's not over, right? This is like a batting cage. You can stay in it as long as you want and continue to study. Study materials and guidance are provided. That's important with simulation. With simulation, you have to have feedback. And now she's going to stay in the batting cage until she reaches a certain level of competence. And now she's going to leave with her A+ and move on to her next competency-based assessment. So you can see where we're going with this. And we really hope that we really are going back to the future with the American Board of Pathology. It's not your grandfather's board, I can promise you that. And we're really working hard to look forward to the future. I've stopped early to give us some time for questions, and I will stop sharing there.
Thank you, Gary. That was just exceptional. I really appreciate it. I want to know if anybody has any questions for Dr. Procop.
Yeah, Debbie, I'll chime in.
Great, John. Thanks.
That was a fantastic presentation. I've been involved in teaching medical students and residents for a few years now, and I found this very, very interesting. I have two very simple questions. Number one, the University of Minnesota has changed their medical school curriculum, and so now we actually are teaching less histology and less pathology than we did in the past. And I'd like to know what you think this is going to do to the field. And the second question, I have always told residents coming into the program that we are actually physicians first and specialists second. And I've emphasized the importance of pathologists really knowing clinical medicine, and I wonder what the American Board of Pathology, how they feel about this, and do they feel that this is important also, and are they doing things to improve the ability of pathologists to actually know clinical medicine and to help the clinicians?
So your first question with regards to histology, I think for our subspecialists, that paper from University of Michigan, demonstrates that, it would be, and our survey of program directors. But the problem is, I don't think, it's tough to change the tact of a medical school if only a small number of your folks are going into pathology. Whether I think the question you'd have to prove to them is, does it make a poorer cardiologist or a poorer pediatric endocrinologist? And maybe it does, but they clearly don't think that right now, that you don't need a histology lab with slides and microscopes and the like. But clearly we believe that it would be a detriment to our field, and that's the reason we kind of put this together. When I presented this at the last APC meeting, one of the next conversation was, we probably need one of these on basic mechanisms in pathology, inflammation, neoplasia, etc., because that may not be being taught either. So again, these are some of the things I'm going to challenge our cooperating societies with, because we can't do all this. We just don't have the bandwidth, right? I don't have the bandwidth. But it would be great if our cooperating societies were to step up and co-create some of these resources for residents. And again, the whole idea here is make them free for residents. I mean, we don't want to raise any fees, etc. So there's that. One of the things, and maybe Debbie has some insights. I know it happened, probably before her tenure even, but the idea of getting rid of the 5th year or the clinical year in pathology, did that have an untoward effect? Because, I think one of the challenges we've often seen is it takes a while to get comfortable to talk to clinicians. You almost have to build an internal expertise, so you feel like you can talk to them on an expertise level, and because those interactions didn't occur early in training. So, of course, we really believe that professionalism, communication, those are really key for a pathologist to function optimally. If not, send everything to a reference laboratory and just let a result come out. But we think a pathologist actually engaged in care delivery gives a better outcome than a pathologist, just giving out a test result, right? So those would be my thoughts. Debbie, any thoughts on that 5th year? I know there's no getting that horse back in the barn, but any thoughts on it?
Yeah. I was actually on the board when we eliminated the 5th year, and I think it was worthwhile, but I think we can do more in training, and that's one of the reasons why I think it's so important for residents to take call, especially in CP, so that they can actually communicate with physicians. And we all, of course, stumble as to how to do graduated responsibility and training. I think your competency-based assessment modules have great promise for that, because I think if you can assess competency as residents are in training, you can give them more authority and independence when they can practice communicating with their clinical colleagues while they're still in a safe space, which is their training environment. So you've got lots of opportunities with that to really reach what we always have thought of as the holy grail of residency training, to actually make them functional pathologists before they leave us, not just in knowledge, but in skills. And that's a skill. Yeah.
One of the things that Mike Laposata, of course, has done is to introduce the concept of diagnostic management teams. And though it seems like a very good concept, I don't think it's adopted very much. I don't know for sure.
Right.
Yeah, I think those were a great idea, and having people, pathologists, be part of the team. But I think you're right, it hasn't happened very, very widely. and it's terrible. Are there other questions for Dr. Procop? I
See
know
my friend Dr. Colleen coming on camera to give me a fastball. Hey, Tony.
Hi, Gary. How are you? Great seminar. Thank you so much. So artificial intelligence, it's impossible to pick up a major newspaper or even a major medical journal these days without some article about the positives and the potential negatives of AI. Where is the board on that? I mean, there's a certificate in informatics, which is combined, I think, with there's another board,
Preventive medicine board, yeah.
Board of Preventive Medicine. But where do you see AI in in pathology training and examinations and certifications and so forth? And related to that, is there a route for PhDs to get certified in this field?
Right. For PhDs, probably not. There just was a large, and a large because it went on for a long time, debate at ABMS about, other boards entering ABMS that are not physicians. So that'd probably be a high bar. It's an ABMS level bar. Of course, we really embrace our PhD colleagues. Many of my best instructors were. So, nothing there. It's just different avenues of certification. But AI, that's going to be our summer retreat topic. I leave for an ABMS meeting, and American Board of Family Medicine basically is sponsoring a dinner away where it's all focused on AI. So many of these boards are extremely worried about it. So
Recording stopped.
We've looked at it a variety of different ways, but definitely are looking into it, and we'll keep you posted on what we decide to, how we decide to incorporate it.
Yeah. Back to the PhD thing. So the American Board of Medical Genetics certifies PhDs, and I don't know if they're the only board, but there's certainly precedents for American ABMS family of boards to include PhDs with.
Right. They do, and there are physicists in radiology. Those basically came in, and believe me, those were the two boards that, spoke for the inclusion. Yeah. There are other boards, and, it's, a lot of it is infringement on professional services that other boards are worried about, to be quite honest. And so anyway, I'm just reporting the facts.
Yeah. Thank you.
Well, thanks so much for having me.
Thank you, Gary. It was really terrific. And I know you're going to meet with our residents now, and we really appreciate your doing that also. So we're excited to hear all this. The board is really taking off, and that's great.
Thanks, Debbie. Appreciate it. Thank you all. Thank you for the opportunity.
Bye.